Good afternoon, teacher. My name is Alexandra Salazar. I have to talk about matrix stiffness and sarcoma ground, the scientific indication of compartments. Definition. Matrix, one of the many mechanical forces acting on cells, is extensively as an important of cell division is regular cell signal broadly which affect and ground survival and motility. The stiffness of tissue has been used for concentrates to detect tumor by simple manual palpation.
Many people ask, what is sarcoma if someone in the family is stricken with this disease? Now, first and foremost, sarcoma is not one disease. There are hundreds of different diseases that are grouped under the general term sarcoma. Sarcoma refers to a growth of cells whose normal function would be to hold the body together. These are called connective tissue cells because they're connecting different parts of the body. And generally speaking, these include cells like muscle, bone, nerves, and other things that don't really have a function in the body other than to hold it together. Any one of these different kinds of cells, fat cells, muscle cells, different types of nerve or nerve protecting cells, blood vessel cells, if they turn cancerous, that type of a cancer is known as a sarcoma. Now, importantly, the different types of sarcomas have more complicated names. So a muscle sarcoma could be either a rhabdomyosarcoma or a leiomyosarcoma. These polysyllabic nightmares are difficult for patients to understand. They're very difficult for physicians to understand unless they are sarcoma experts. And frankly, it's been very confusing in the field of medical research. And part of what our team is trying to do with expert pathologists like Chris Fletcher at the Brigham and Women's Hospital is to try to make these different sarcomas actually different diseases that we treat in different ways. The analogy is simple. If you get an infection, you try to figure out what bug is causing the infection, and then the doctors can treat that specific bug. It's exactly the same with sarcomas. If a patient or a loved one gets a sarcoma, you want to be sure you're getting the exact right type of treatment for that exact right type of sarcoma. Part of what our team here is focused on is understanding all the different types of sarcomas in as much detail as we can, right down to the level of the DNA. Because sometimes, as in the case with the sarcoma known as gastrointestinal stromal tumor, or GIST, the DNA and the mutations in the DNA of the tumor can give us clues as to important new molecular treatments that may be developed to fight that type of sarcoma. When a patient or family member is diagnosed with a sarcoma, there are many decisions to be made very quickly. The national guidelines from the National Comprehensive Cancer Center Network strongly encourage patients to seek an expert opinion at a sarcoma center or a center where the physicians there work as a team and have extensive experience in the management of patients with multiple kinds of sarcomas. The Dana-Farber Brigham and Women's Cancer Center, part of the Dana-Farber Harvard Cancer Center, has extensive experience in our hospitals, and we have an extensive team of multidisciplinary specialists, including medical oncology, surgical oncology, orthopedic oncology, pathology, reconstructive surgery, and many, many other specialties that work together in a coordinated team to help provide the best care for patients, whether it be using standard and conventional measures that local physicians could also deliver, or whether it be in the cutting-edge new research studies that are available at our center. We encourage patients to use this expertise here, and we work closely with other centers worldwide so that we can advance the care and the outcomes for patients with sarcomas so that they can be the best they can possibly be.
Dentistry part. Resin bonding to dentin requires the use of cell aging priming or acid aging to descalcify the surface and spoils a layer of collagen fiber of the dentin matrix. Acid aging reduces the stiffness of the mineralization dentin from recurring that it floods in water to prevent it from collapsing during bonding process.
There's a very broad range of how they behave. So, what is your approach to the tumor, the sarcomas in the advanced or metastatic setting? Sure. So the first thing we want to make sure we have, outstanding imaging because we want to know before we make a surgical decision, we try our best to get the surgical onset of disease. So in a patient with metastatic disease, depending on how many sites of metastasis they have, it because we do believe that surgery for sarcoma is an incredibly important part of our armamentarium to treat these tumors. So we would look to see, is this person going to be able to get surgically resected to almost no residual disease? A lot of the studies that have looked at this have looked at patients that are going to reduce to R0 or minimal residual disease, because that will just help the chemotherapy work better for the microscopic disease that we don't see.
You've seen it with lung metastasis as well.
Absolutely.
Even if there's upwards of 8 to 10,
sure.
they actually don't know.
Sure. So we look at that, and then we look at, is this patient going to tolerate a very big surgery? For example, if they have a metastatic uterine leiomyosarcoma, they've got an omental metastasis and isolated metastasis to the liver. If we can surgically debulk all of that, then, and it's in a recurrent setting and they've got a long progression-free survival, that might be the patient to do surgery in. But we want to make sure that they're healthy, they have a good performance status, that they're going to be able to tolerate a long surgery, they're going to be able to tolerate a large blood loss, because oftentimes sarcoma surgery tends to be very bloody. So we want to make sure that they're going to be able to tolerate all of those things, because we're not doing them any services if they have a huge blood loss and have been renal failure, end up in the ICU and can't get chemotherapy, which is ultimately what is going to help them. So I think that it's very important to look at all those factors when deciding if surgery is the right approach. For example, we had a case about a year and a half ago of a sarcoma that looked quite adherent to the aorta. It was actually a retroperitoneal sarcoma, we think extending from the uterus, and we elected not to do surgery because we didn't think that we could safely approach that patient.
You mentioned the thing about aggressiveness, right? I think that's a multifactorial part of the equation to sort of do aggressiveness. So first off, you have how is the tumor behaving, right?
Sure.
That's largely part of it takes into account the grade.
Sure.
So the grade, looking at the microscope, how many cells dividing, how close is there, how we're just looking for normal cells. And so I think that grade is kind of a double-edged sword. Some tumors can be very aggressive and also be more responsive to chemo.
Sure.
So, whereas if you have even a moderately aggressive tumor, but it is not responsive to any therapies, it makes our job a bit more difficult.
Sure, absolutely.
If I say I had a patient who was in really bad shape, had a very poor performance status, but if that was caused by the tumor and it was likely to respond, I would be pretty aggressive.
Sure.
Right? Now, it changes the equation if someone comes in, they have a lot of different medical comorbidities, and you're not sure they're going to be able to tolerate that.
Right.
And that really is where my approach is really to talk to the patient about the balance. Right?
Absolutely.
There's a balance between toxicity and aka quality of life.
Absolutely.
Versus tumor control, less length of life. Right? Every patient is different, and so oftentimes I will see patients that are already metastatic, that are not surgical candidates, and where surgery wouldn't make sense to them. But we can get to that point if they have responses. And that balance is different for every person. So what is your discussion with patients about how aggressive you can be and what you would do for them based on what their values are and what their performance is?
Right. And I think you bring up probably the most important point in this conversation is we have to be realistic with our patients. In a widely metastatic sarcoma, we are probably not going for cure in those patients. We're going for extending quality of life, but and as well as quantity as well, and we want to make sure that we're not harming our patients. So I think it's important to really sit down with our patients, discuss, what are really the pros and cons of a surgical approach. One thing that often comes up in my discussion with patients is the creation of an ostomy, urostomy or colostomy, because there are some people that in their mind they don't want to have that, and it's a quality of life issue, and that's not for me to decide or for you to decide, it's for the patient to decide. And so we just present all of those options, and we say, if we do this and we're able to get all of it out, you have a very mitotically active sarcoma, it will likely respond to chemo afterwards. This is something we think would benefit you with these possible side effects, surgically. And so I think that's kind of that balance, exactly as you said, with kind of talking about side effects / results of surgery versus how much quality we're giving patients.
I'm not sure if you see this as well. I'm sure patients come in and say, what are my chances?
Right.
What are my chances? What's the percentages? The problem is, and what I tell them is that, look, individuals are binary, 0 or 100%.
Right.
There's no in between.
Right.
And so we won't know until you try it. Right? So oftentimes when I say, if they're really worried about the side effects of chemotherapy, I say, well, it's important to see how you tolerate that. Sure. Because I've seen some people in their 80s that do great with chemotherapy.
Absolutely.
No problems. I also see people in their 30s that have a horrible time with it.
Right.
But that's that comes from the conversation quite a bit. I think as you're right. It's really important to be honest with patients to sort of prepare and understand what the stakes are. What's important.
No, absolutely.
Studies in Ecuador, studies in common cancer of epithelial origin have been useful in the identification of candidates molecular pathway involved in metastatic and therapeutic resistance in sarcoma. The mesenchymal origin of sarcoma makes them unique and cellular processes like AIMT and NIMT cannot be diffused in the same manner as in epithelial tumors.
Soft tissue sarcomas, the importance of proper biopsy and surgical excision technique. Soft tissue sarcomas are cancerous tumors that can grow in any region of the body, though they are most commonly found in the limbs and abdomen. They grow from certain tissues, such as muscles and tendons, fat, lymph nodes, blood vessels, and nerves. However, sarcomas are rare, while similarly appearing benign tumors are common, which is why many sarcomas are improperly surgically removed due to the incorrect assumption that the soft tissue tumor is benign. So, it is important to have a soft tissue tumor biopsied by an orthopedic oncologist. The soft tissue sarcoma shown here is growing in the deep anterior compartment muscles of the thigh. If the tumor type is improperly diagnosed, an unplanned surgical excision or removal may be undertaken. This may result in several long-term negative consequences. First, the incision that is created using improper surgical technique often makes a large transverse skin defect. Secondly, when the soft tissue sarcoma tumor is removed, the tumor is often excised without a large enough tumor-free tissue margin, which will leave cancerous tumor cells behind in the body, leading to an increased chance of recurrence of the soft tissue sarcoma and requiring later removal of the contaminated tissue. The closure also leaves a large transverse scar on the thigh, often leading to unnecessary morbidity or disease and plastic surgery skin reconstruction. When an experienced orthopedic oncologist discovers what they believe is a soft tissue sarcoma, the surgeon will first decide which type of biopsy is best for the individual patient, an image-guided needle biopsy or an incisional surgical biopsy. Image-guided needle biopsy is a technique where the surgeon inserts a biopsy needle into the sarcoma with the aid of imaging technology, such as ultrasound, ensuring the needle is placed correctly. After, the sample is sent for pathological analysis, which will determine if it is a soft tissue sarcoma. Surgical incisional biopsy is a technique where the surgeon makes a small 3 to 4 centimeter longitudinal incision on the anterior or front of the thigh. Then, the surgeon exposes the sarcoma and removes a small sample of the tumor. The sample is sent for pathological analysis, which will determine if it is a soft tissue sarcoma. The incision is then closed, leaving a very small indication of the biopsy. Several days after the surgical incisional biopsy, a diagnosis of the tumor will be finalized. If the diagnosis is positive, preoperative radiation therapy will most likely be ordered, after which the tumor will be surgically removed with a sufficient tumor-free margin, usually 1 to 2 centimeters of tissue around the tumor, so that recurrence of the soft tissue sarcoma is minimized. With the proper diagnosis and removal of a soft tissue sarcoma, the 5-year survival rate is very good for patients, 83% for localized tumors without metastasis or spreading. So, it is important to handle soft tissue sarcomas in a manner that will enhance the patient's long-term prognosis.
Pros y cons. Self-proliferation and differentiation are often thinly like process and regulated by growth factor, such as TGFB, platelet derived growth factor, and fibroblast growth factor is in mesenchymal stem cell. TGFB, in particular, is known as a key regulation of the AMT phenomenon and the associated tumor progression in multiple tumor types. Conclusion: studies in common cancer of epithelial origin have been useful in the identification of candidate molecular pathways involved in metastatic and therapeutic resistance in sarcoma. However, the mesenchymal origin of sarcoma may be unique and cellular process in the same water and epithelial tumor.